Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. I'm your host, Jacob Hutcherson. Today I'm honored to be joined by Chaz Rhone, a true leader and advocate in the field of infection prevention. Chaz's extensive experience and dedication to patient safety have earned him recognition as an APIC Hero, champion, and fellow. With over 15 years of varied experience in acute and long-term care, Chaz brings a wealth of knowledge and expertise to his role as AVP of Infection Prevention at HCA Healthcare North Florida Division. In this episode, we'll have the privilege of delving into Chaz's remarkable journey. As a board-certified infection preventionist, epidemiologist, and consultant, Chaz is passionate about keeping patients safe, developing leadership in infection preventionists, and advocating for those with public health backgrounds. With a Master of Public Health under his belt, Chaz's dedication to advancing infection prevention practices is truly inspiring. Join us as we explore Chaz's insights, discuss his advocacy efforts, and uncover the keys to effective leadership in infection prevention.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
Thanks for having me on today. I'm Chaz Rhone. I'm the Assistant Vice President of Infection Prevention for HCA Healthcare, specifically the North Florida Division.
It looks like your very first job was an internship straight out of college, MPH degree. So did you know you were going to be an infection preventionist for your life, or when did you kind of discover that this was even a thing?
Yeah, so before the internship, so let me start by saying my original dream was to be a physician. And so I did undergrad, I did pre-med, and I, tried to do all the prereqs, and I struggled through undergrad, and it wasn't easy in the least. By the time I made my way through undergrad, I wasn't sure if it was really something that I wanted to continue on. So I actually went to go see one of the advisors at the University of Florida where I was going at the time, just to kind of discuss options. So is there something that I can do now to better prepare for med school? Or are there other options, of things that I might be interested in? And they're like, well, we have a Master's of Public Health program that's just launched. I think they were like 2 semesters in already. And they suggested that this would be a good degree no matter what healthcare field that I went into. It will be a nice overview of public health and some of the things that you would accomplish in healthcare anyway. So I kind of was like, okay, I'll check this out. At least I'll be earning another degree while I decide, what's going to be next. And so kind of went through the program, and as most MPHs know, at the end of your program, you usually have to do a capstone project, which entails some type of interning or research or whatever you choose. And so as a part of preparing for those, they allowed us to sit in on the presentations from the class that was ahead of us. And so I sat in on several presentations, and one of them was about infection prevention. And so I actually still know this guy today. We've stayed in touch. But he did his internship in infection prevention. He did a project specifically around catheter-associated UTIs. And as part of his project, he really explained what infection prevention was. And I was like, wow, this sounds very interesting. It's the perfect marriage of what we learn in epidemiology, but it's balanced and it's applied in a healthcare setting. And I knew I still wanted to be in healthcare, just didn't know quite how or what that would look like after going through undergrad. So to say the least, I kind of connected with him, and he connected me with his preceptor, and I ended up doing an internship there as well. Just really fell in love with the nature of the work. You're not directly caring for patients, but everything you touch impacts patient care. So I just thought it was a really neat job, a really neat profession. And so I just kind of pursued it from there.
That's awesome. The person that presented was this person also an MPH working in a hospital?
Yes. Mm-hmm.
Okay. Okay. So you had a model there. Okay. So then the internship that you took, looks like you did it for a few months. Was that a paid internship, and how many hours was that?
So it was not paid because I got credits for it towards
Gotcha.
my degree. But I think if I recall correctly, I think it was a full-time thing. So
Wow. Okay.
you can choose how many credits you want to work on, but I was trying to grind it out and get done, that last
Gotcha.
semester. So I had all my classes done. So my full last semester was strictly spent on an internship, and I think I did it over a summer semester. So I just worked there full time, and I really worked closely with the IP director there. There was another IP coordinator there at the time, and really got to see everything IPs do, even though my project was focused on a small part of that. But I still got to round and, go to the ICUs and look at the OR and sterile processing. So I was really exposed to the full scope of IP, even though my project was focused on a specific function. So
Gotcha.
it was a great
Now,
experience.
that's awesome. So how big of a facility was that? You said you had two other people in the department, sounded like, that you worked with. So how big of a hospital was it? And then when you started kind of doing your internship, was there a point to where you were like, okay, yeah, this is my career, or like, this is what I want to do? Or was there a point where you just were totally shocked by any of the responsibilities?
So I think it was like a 200 bed facility, if I remember correctly. Interestingly enough, it's actually not there anymore. It was torn
Okay.
down in Gainesville, Florida. It used to be Alachua, uh, I can't remember, Alachua Hospital, I guess, but it's not there anymore. Um, but the crazy thing is, my preceptor now works in one of my facilities that I oversee in my current position. So all
That's
these
awesome.
years later, the person that introduced me to IP and really set the foundation of what it is for me, I still work with her. So I thought that was pretty cool.
That's neat.
I can't recall a specific moment that I was like, this is what I want to do. I just think it was kind of a gradual transition, also coupled with the fact that I had already started applying for jobs, and the salaries I was seeing, I was just like, I'm not going to be able to live on this, And I'm like, I'm getting a master's degree, and these salaries are very concerning. So, I think that also convinced me that, hey, I probably should kind of stick around the hospital setting, because the impression was that the salaries would be higher in
Yeah.
that setting. So.
Gotcha. And then was there anything in the internship, and then obviously in the next job, we'll talk about it too, but was there anything that just surprised you that you just weren't accounting for at all?
I think just the scope that IP covers, and even looking back, the glimpse that I got in that internship was a big scope, but it's even bigger than what I experienced in that internship. So it was very eye-opening, but it was also very interesting to me. It made me more interested in the position, just because of the scope and the impact that it actually has, the level of importance that it carries, the significant impact that you can have on keeping patients safe. I was really kind of drawn to that. So.
Awesome. Okay. So it looks like you did it for um did the internship for a few months. Then, I mean, you're pretty quickly able to leverage that to a full-time position in a hospital. So tell me about this. One, you're going in, I'm sure 3 months of experience helped. Master's degree is going to help. But still, especially in 2007, it's probably more of a nursing role, or at least
Right.
thought of to be. So how did you land this job? What was the interview process like? How did you go about convincing them that you could do this?
Yeah, so this is, and I'm sure you'll ask me some tips later on, but this is one that I learned very early. One of my preceptors came to tell me, or one of my mentors came to tell me, it's not always what you know, but it's also who you know. And so this was actually a perfect example of that. So the preceptor that I was working with, if you don't know, IPs are pretty well connected. So they usually have a local APIC chapter, or they just know each other because they've moved from hospital to hospital. So they're very well connected. And so my preceptor in the internship actually knew the director where I was applying for a position. And so that position posting actually specifically requested a nurse. And I applied for the position anyway. And the way I was even able to land an interview is because my preceptor knew the director there, and she contacted her on my behalf and said, "Hey, this guy's done some great work while he's been here. I know he's not a nurse, but you should at least interview him and see where it goes from there." And so, I at least got my chance to interview and tell my side of the story, even though I didn't meet the requirements that they had put out there. So saying that to say, even if it asked for a nurse, I would still apply anyway. But if there's a way to get around that HR system or that screening process through a connection, then you want to take advantage of that. But in the interview, I spoke with the person I would be reporting to, but I also spoke to the medical director or the hospital epidemiologist for the program. And so my concentration and my degree was also in epidemiology. And so I really talked about how I would apply those skills in the infection prevention setting. And I also talked about what I did in my project to demonstrate my skills that I had learned as part of my degree. And he was very impressed by that. So I think him recognizing the skill set that I bring to the table, and in addition to the nurses that were already working there, kind of pushed them over into, yeah, we want to bring this guy on, even though we asked for a nurse and hadn't considered an MPH. So I think that's
No,
really
that's great. Yeah, that's great. And I'm glad you mentioned the part about just leveraging your network, because yeah, if it's near impossible to get through HR if you don't meet every or check every box on the job description. And that's regardless if the hiring manager would hire you or not. A lot of times they don't see it. So
Exactly.
that's interesting. Okay. So you got the job, which was great. So tell me about the job now that you're in it. Obviously you were able to leverage some people and convince the doc there. But what about the team and the rest of the hospital? Because it sounds like you're probably the first non-nurse working an infection prevention role at the hospital. So you had to make some inroads somehow. So what was the overall reception you got from the hospital community, and how did you deal with it?
Yeah, I honestly think the reception was good because I think everyone assumes you are a nurse unless you tell them otherwise. And even when I told them that I had a master's in public health, they would be like, "Oh, what's that?" But I don't think there was ever any, obsession over, "Oh, you're not a nurse. You don't know what you're talking about." I never experienced any of that, fortunately, in my first role. I can tell you I was paired with another nurse, an ICU critical care nurse that was an infection preventionist. And she taught me everything clinically that I know today. She took me everywhere. She involved me in almost every conversation she had. She would point out things that she was seeing in terms of patient care and in the clinical environment. And again, I've only had limited experience in the hospital before starting that job. So that first actual job was very instrumental in my career in terms of getting up to speed with the clinical piece of it. So looking at signs and symptoms of patients and, being able to interpret that to see if we're concerned about infection. This was also at a time where the NHSN criteria was not as black and white as it is now. So there was still some clinical interpretation that was required. And so, that was very formative for me to be able to talk through some of those examples, actually looking at, the patient clinically instead of from a surveillance standpoint and how that applies to infection prevention. So that was eye-opening and career changing for me as well.
Okay. And that's what I was going to ask next. You mentioned, and you hit on this. I was going to say, how did you pick up, or how would you advise a non-nurse pick up the clinical experience, or the clinical knowledge rather, that's necessary for the role? You mentioned teaming up with another IP there. That was a nurse. That was kind of a mentor. Do you have any other kind of, I don't know, tips or advice, creative ways to like pick that up or fast track your knowledge once you get into
Um,
it?
I I think the only way to do it is being in the environment, and knowing to ask questions, knowing to be okay not knowing, and telling them I'm here to learn. If you don't have another IP nurse that you can pair up with and kind of go out and look at that, I would just go work in the ICU for a day and shadow a nurse. So, I know in subsequent roles, I built those types of relationships and I actually did some of that. I would work a shift with an ICU nurse to see everything they see, look at it through their eyes, and along the way learn some things about maybe some barriers that exist in terms of what we're asking them to do. So, or what our expectations are from an IP perspective. It's easy to tell them what you think they should do, but once you actually are in their shoes and you're doing the things that they're doing, sometimes it's not as simple as, hey, you need to be doing X, Y, Z. It really helps you understand what the limitations or the barriers are so you can really address those.
Okay. And one more question that just kind of hit me. When you were in this role, did you realize your background was kind of odd compared to the rest of the country? Because I got to think at this point, I mean, now it's probably a lot closer to 50-50 non-nurse versus nurse. But at this point, you have to be less than 10%, I would imagine. Did you realize that yet? Or did that take some years before that was kind of acknowledged?
I don't know if I fully realized it. I knew a lot of jobs I think every job I looked at asked for a nurse.
Mm-hmm.
And obviously I didn't have that. So I was just like, what the heck, I'll apply anyway. I have some experience. I've done an internship, so we'll see what happens. But I don't think that I was aware, that, hey, this is really rare or an exception. And I think it's because fortunately I did find my way in so easily, which I know has not been everyone's experience. And so, now being on the other side of that and realizing that, hey, this is, you said 10%, I would say it was probably less than 1% back then. So this
Yeah.
is
Okay.
2007, 2008. Even right now today, it's still less than 10% for MPHs being IP. So it unfortunately is still pretty rare.
Yeah.
But
I guess you're right.
saying
I guess
that
it
to
is more the
say,
lab background.
right, saying that
Yeah.
to say, it really has prompted me to open the door for others. Now knowing how difficult it can be, and advocate for others, knowing the skill set that we bring to the table and the importance of those skills on an infection prevention team. And so, obviously you don't have to be a nurse. I've been successful in my career. I've been able to learn enough about the clinical environment to be successful as an IP. It's still a learning curve in some situations, but even if you think about a nurse, an ICU nurse and an OR nurse, they have different skill sets. They have different knowledge sets. And so even a nurse going into IP, you're still going to be in the OR. You're going to be in SPD. You're going to be in a lot of areas where you've never cared for patients in, and it is a different skill set. So, there's even a learning curve for nurses when they go and they broaden their scope to other areas. So, saying that to say we all come to the table with some sort of knowledge deficit, but we all bring a unique skill set that's necessary for IP. So the goal would be for each of us to know what our deficits are and get better in those areas to become a well-rounded IP. So,
Yeah, that's a great answer. Well, okay. So you do this for 3 years.
mhm.
Then, correct me if I'm wrong, but you make the jump back into public health at this point. So, what
Yes.
went through your mind? Would you do it again? Um, I don't know. Just compare the two. What was going on in your head?
Yeah, so I might get a lot of haters when I say this, but I was never really that interested in traditional public health. I always knew that I wanted to work in the healthcare setting specifically. So I looked at jobs at the health department, but again, and I know my health department people can appreciate this. The salaries just are not there. They
Yeah.
aren't. And so that's a big limitation to attract talent. So So this opportunity, while it was with the Department of Health, it was still specific to infection prevention. So I thought, again, it was an opportunity to use my skill set and on a broader scope. So as opposed to working in one facility, now I would have a role at the state and potentially engage many hospitals throughout the state to help them make their infection prevention program better. The primary goal of that role was to get hospitals enrolled in the National Healthcare Safety Network. That was around the time when CMS was going to start requiring hospitals to report healthcare
Gotcha.
associated infections and withhold reimbursement if they were not reporting and if they were not performing well compared to their peers. So before that was a requirement, CDC gave grant money to each state to start an HAI program uh, under the guise of let's get them into NHSN, but as you're doing that, let's teach them about infection prevention as well. And so the first required infection that was to be submitted through NHSN was catheter associated UTI. And so I did get a lot of facilities enrolled into NHSN, but I also was able to counsel them on best practices to prevent catheter tract infections. So it was a really cool job. I met many IPs all up and down the state of Florida. Spent a lot of time in South Florida, so Miami-Dade area, even the Keys, all the way up to Jacksonville, and did quite a bit in the Tampa area because that's where our office was based. So that really gained me a lot of acquaintances and connections in the IP setting. People knew who I was. I would do site visits and go to their facilities and speak with their staff. We actually did cohorts or collaboratives, and so I would actually have monthly calls with those who are involved in it. So it really helped me to establish relationships and be a subject matter expert and a support to the IPs that were out in the field. So it was not a traditional public health job. It was still specific to IP, and so I loved it. It was still in line with what I was
Yeah. No, that's great. That's not at all what I was expecting when I saw that on your resume there. So that's awesome.
doing. Yeah.
So sounds like great experience there, and I want to get into the networking and kind of management piece in a second. But this surprises me a little bit because you've got, let's see, about 6 years of infection prevention experience, which is a lot, especially at this time. I I remember when I first started recruiting in 2012, it was, if you got 3 years of experience, I can leverage that to get you just about any job you want. So you've got 6 years, but then it surprises me that you took a staff level position next, and you did that for another 6 years, and it's in Tampa, so that may have been part of it. But what caused you to jump back into not that you left the hospital setting
Yeah.
because of your job, but
Yeah.
what caused you to be employed by a hospital again,
Yeah.
and then
So
specifically a staff level role?
yeah, so I don't want everyone to think that I'm just chasing dollars, but let me be transparent. We want to get paid for what we do, right? And
Absolutely.
so the position at the health department was actually grant funded, and the grant was coming to an end. And so I could either shift into a traditional public health role, still sort of related to healthcare associated infections and infection prevention, but more so in the community outbreak space and that sort of thing. I wasn't interested in doing that. And I also knew that I would make more money than I was in that current position if I went back to the hospital.
Gotcha.
You're saying that 6 years is a lot of experience now. I definitely agree with that. Back then, I don't think it was appreciated as much as it is now because we just had more experienced, more tenured IPs during that time. And also, I am now aware that it is hard for MPHs to land jobs, not only as IPs, but especially in a leadership position as an
Mm-hmm.
IP. And so while I wasn't, sort of in a leadership position in the role I was in at the health department, I was interacting with at least 50 hospitals throughout my time there, directors and programs. And so I was used to overseeing, I,
Right.
not that I oversaw everything that they did, but I had to keep up with 50 different hospitals, what they're doing, how they're doing it, help them come up with action plans and that sort of thing. So I think it did set me up for a leadership type position, but there just weren't any at the time, and specifically for an MPH to get into. But
Yeah.
what I did know is that TGH, or Tampa General Hospital, was very open to MPHs. They're a very large program. They're a very large hospital. They have lots of resources in their infection prevention program. So I knew it was somewhere that I would be able to grow. They also have service lines that I had never been exposed to. So there's a burn ICU, there's a NICU there. They do transplants. They pretty much do everything. And so all the service lines that I never had exposure to, I was interested in getting exposure. And I knew I would get that if I worked in a program that was that large. And so I took the position. It was a good salary. It was a great team. And again, lots of opportunity for growth in terms of broadening my body of knowledge when it comes to infection prevention. Again, connections. So the person who was my preceptor when I started at Tampa General is now one of my counterparts in a different division. So we are still connected. We still work together, and we kind of grew up in infection prevention together. So it's
That's
pretty
neat.
cool.
Um, okay. So looks like 6 years, 6 years in this position. Um, you said they were MPH friendly, so I imagine you weren't the first, and um, good reception there, and continue to grow in what you had. So jumping to your next spot. So you were here 6 years, then you end up landing a division manager position with HCA where you are now. This was 2019, it looks like, and you've jumped up the ladder pretty quickly through HCA. So how did you, I mean, it's a big, you can tell me the scope of it, but it's seemingly
Yeah.
staff level position, staff level for your whole career. Obviously, you've had a lot of experience working with the system, so I'm sure the public health job really helped here.
Mhm.
But how did you convince HCA to bring you on in a division manager role, having never directly managed somebody?
Yeah, my path is a little rare, I think, when we look at most others. And I saw your post on LinkedIn the other day, kind of
Mm-hmm.
outlining what the progression of an IP looks like, and I completely agree with that for most people. I think my jump is a blessing and a curse. So at Tampa General, even though you don't have the title there, we were put in a position to learn a lot about leadership. So we were all assigned programs and committees and projects to work on, and we were the contact person for that. So we had to prepare a meeting agenda, slides, data. We had to do all of that for whatever project we were assigned to. We also had to work with the people to make progress on our goals. And so it was really good exposure. We also got to work a lot with senior leaders, even as staff level IPs, to move our program forward. And so, while I didn't have the title there, a lot of the function was that of a manager or director, just because of the level of scope and interaction that you have with the levels of leadership within the facility and the expectation to be the person for the program or the project that you're managing. So it was really a great experience there. The reason that I ended up leaving TGH is, like a lot of other hospitals, there are not enough levels of infection prevention to show progress in your career. And so at the time, there were staff level IPs and there was a director. Um, and then, I think about maybe a year to 6 months before I ended up leaving, they finally added a manager role. I applied for the role, but I was not selected for the role. But I appreciated the fact that they were adding in, layers to show
Mm-hmm.
progress in your career. But knowing that I was ready for my next steps, I ended up applying at HCA, and I landed the role. So again, this is another example of, it's not necessarily what you know, it's who you know as well. And so my stories are just crazy. So when I left my first position at Monroe Regional Hospital in Ocala, the IP that came in to replace me was my boss when I went to HCA. So we did not ever meet, but she knew about me and she knew who I was because she was working with the people that I worked with when she came in right behind me. So she kind of knew my reputation. She saw my work, obviously. She knew a little bit about me. We were connected on LinkedIn. I'll connect to pretty much any IP out there, whether I know you or not, just in case, or just if I have a question or if I want a resource or what have you, or even to connect you to someone. So when I saw the position, I was like, I'm pretty sure I know someone, just thinking through my LinkedIn connections that works here. Enough, I went to search and it was her, and I reached out to her and I'm like, I'm interested in this position. Can you tell me a little bit more? And she was like, I am very glad you're interested in this position. And so we talked about it, we interviewed, and the rest is history. So.
Wow, no, it's outstanding. Um, Going back to your Tampa General position, you mentioned you were kind of functioning, you were leading projects and whatnot.
Mhm.
Was that just something that Tampa General did in their department, or was this something to where you had to go to the director and say, "Hey, I'd love to run some projects, or I'd love to manage this particular thing," or was that more of just kind of thrown on every IP that was there?
It's an expectation of their program. It is I would say it's a very progressive and highly functioning program. It is one of the best infection programs.
Nice.
I think they got recognition for that within the last couple of years, if I'm not mistaken. But it is a great training ground for IPs to prepare them, to go on into their next steps in leadership. So
Yeah.
um, and outside of that, what I will say, and this is kind of another piece of advice for IPs out there, while I was working there, I also did a lot of things external to the facility, but to still advance my growth as an IP. So I was involved with Florida Professionals in Infection Control. I was involved with APIC. I participated in some projects and fellowships that APIC was doing at the time. Went to as many conferences and meetings as I could, participated in my local APIC chapter to get connected. So while I was there, even though I got a lot of exposure in the hospital to build some leadership skills, I was also doing things outside of the hospital to also enhance my resume as well and to get my name out there,
Mhm.
knowing that I would eventually be taking my next step. So.
Yeah. No, it's great. And I'm glad you jumped into that because I was going to hone in on the networking piece. Obviously, it's been a big part of your career and something that you would advise. When did you start? I mean, I guess you learned pretty quickly that IP was a small world. But when did you start making like a intentional effort to connect with other IPs and really kind of grow that network you have?
I think it started at Tampa General, and I think it's because our local APIC chapter in Tampa is very large, and a
Gotcha.
lot of us know each other. So I've actually graduated with some IPs that still work in the Tampa area. We kind of grew up together, so really just kind of stayed in touch in that community. But also coupled with my exposure in the health department job where I traveled all over the state, even at our state infection prevention conference, I knew a lot of people there as well. So initially, a lot of my connections were just because I had met people, I had worked with them, and we just geographically worked in the same community. But I really kind of shifted to social media. I think, maybe my last year at TGH. I really fell into LinkedIn and I'm like, let me see what's out there, let me see if I can connect to other IPs, just to learn who's out there, what their backgrounds are, what their struggles are, what advice they might have, even to help recruit people to the team that I was on, who's out there and do they want to come to Tampa and work on our team?
Hmm.
Because as we know, it's really hard to replace IPs when they leave your team. And so, a big part of that motivation was just to connect to people to say, hey, we have an open position. Are you interested to come and work here? Just another venue to put job postings out there, is really why I went to LinkedIn. But then it kind of evolved into something else that I never really anticipated. So, um, So my shift from Tampa General to HCA, I had mentioned that was a blessing and a curse. A blessing because obviously I was able to land a leadership position, not just over one hospital, but my initial position was over 5 facilities when I went to HCA. It's a curse in that I have never worked as a staff IP with HCA, and I have never been a facility director in any facility as an IP. And so, number one, HCA is very regimented and standardized in the way they approach infection prevention. So I had to learn how infection preventionists in the facility do their job so that I could teach other IPs to do it. Never having done it myself. So that was kind of a learning curve, but I had great support with that. But in terms of the leadership piece of it, I really think that it came naturally to me. So while I did enjoy being a staff IP, I actually really enjoyed my job at the Department of Health because it was more of a consulting and coaching type role as opposed to I'm actually at the facility. I'm the one doing the work. I'm responsible for the outcomes. I have to navigate within the hierarchy and the reporting structure and the red tape, the politics. You don't have to do that as a consultant.
Right.
And the reason I'm saying that isn't out of convenience. It's because I know what it's like to be a staff IP and how you can feel from day to day with the struggles that you experience. Um, so I enjoy being able to be outside of that so I can maintain a positive attitude and then encourage the ones that are the boots on the ground to keep going every day. Especially having gone through the pandemic and stuff like that, I can't imagine what it would have been like for me to be in a facility working as an IP. But I knew my role was to encourage, support, be a resource, do everything that I can to help them stay positive where they were. And that was even more evident throughout the pandemic. And that's what I enjoy doing. So it was a
Yeah.
natural fit for me.
Now, just just for my own sake, a position like this doesn't exist anymore in public health departments, correct? The position you held?
It does, but it has evolved quite a bit.
Okay.
And so it's shifted more from, let's get everybody enrolled to NHSN because most hospitals are doing that now. They're aware of the program and the reimbursements and that sort of thing. So now it is how do we use the data that comes into NHSN to identify facilities that may need some assistance and support? And then we'll go and do an assessment and help them educate and come up with an action plan. So it's still functioning to serve an infection prevention purpose, but just in a little bit different way.
Okay. I was just saying, because the people that I've talked to in public health roles, it just doesn't seem to be near as much overlap that you may have had in your role.
Yeah.
So just interesting. Okay. Um, great. And then just to close out the kind of career track, I mean, now you're an AVP over a division. Looks like you were an interim division AVP for a second. So
Mhm.
did a position just open up? You were the manager at the time, so it was just a natural fill in, and then they just decided you're doing well enough, we'll just keep you. Is that how that played out? Or
So this is I'm going to throw out a term here. Succession planning is very important in any career track, really. And so my previous leader, who was the person that I knew that left when I left my first role, came in behind me. She was serious about succession planning, and so she gave me opportunities. She gave me exposure to really grow me and prepare me for the role. She didn't anticipate when she would be leaving or when that would be. But the goal there is to always be preparing someone to step into your role when and if you have to leave or and if you want to leave. And that's very widely supported at HCA, not just in the IP service line, but just about any service line you can think of. So, CNOs, CEOs, CMOs, they all have some sort of succession planning model so that people are prepared to step into that next position when it comes open. And so I did not even anticipate that my current role would be open as soon as it did. But the reason that it did is because there was a step for my previous leader to take to advance her career. And then
Gotcha.
it's a domino effect. So everyone downstream kind of takes a step up based on that. So I wasn't just given the role because I was the next in line. I was offered the role because in the role that I was in previously, I demonstrated that I was prepared to do it. But the only reason I was prepared to do it is because my previous leader poured into me and she prepared me to take the role once she moved on. So
That's awesome.
yeah.
So are you still over the 5 hospitals, or did this involve a much bigger scope?
Yeah, so this has taken my scope from 5 hospitals to 15 now,
Okay.
with a couple under construction and lots of freestanding EDs being added every day. So,
So tell me, what is the difference then in a division manager versus the division AVP? Obviously, you have more things you're responsible for, but is this a higher level, more corporate role compared to the manager, or like what were the differences there day to day for you?
yeah, so the manager function was really to help onboard new infection preventionists in the facilities because some facility there is no one else there that's an IP.
Yep.
So to offer support, we did a lot of surveillance. So to try to take that off of the facility IP's plate so that they could be out rounding and seeing what's going on in the hospital instead of sitting at a desk doing surveillance. And then helping facilitate conversations between the local IP leader and the local leadership within the facility. So to help with alignment, in terms of what we're trying to accomplish as a company and also as a division. So just helping with that alignment between the facility IP and their facility leadership. And being a liaison between the two, to come to mutual agreements and understanding. So basically, any support that they needed, we were more boots on the ground, more in the facility, working side by side at the time. But
Mhm.
then COVID came and changed a little bit of that. So then my role shifted into filling vacancies. So if there was no IP, I would have to go and spend some time at that facility to make sure, things were in order from an infection prevention perspective. Also, just taking as much away from their plate as possible in terms of any work that could be done remotely. So again, all of their surveillance, whatever day-to-day tasks that could be accomplished, from remotely from a computer, so
Mhm.
that they would be free to be out in meetings with their teams, figuring out what we're going to do about COVID, and also being out there rounding and being a resource to the staff. And so shifting into the AVP role, again, this role now looks different than it did, especially during COVID. So if you can imagine during COVID, a lot of it was sitting in meetings, figuring out strategy, looking at numbers, deciding, are we going to be universal masking this week? Are we not going to be universal masking this week? How many staff are sick? How many staff do we have out? What's the number of, COVID patients in the hospital? Do we have enough PPE? So it was very focused on COVID. But just prior to COVID, a lot of it was building infrastructure for the IPs and the hospitals within the division. So we got the division model stood up. COVID happened, so it all kind of shifted into support mode. And now that we're kind of on the tail end of COVID, or it's waning a lot more than it was, there's now an opportunity to revisit that infrastructure piece, that standardization piece, that back to the basics piece. And so my role hasn't been so much as focused on COVID uh, in that regard, but strategy around how do we align all of our facilities around best practice and IP? How do we make sure that the IPs in the facilities have everything they need? How do we make sure that we are doing things to make sure they want to stay in their role? So they feel wanted, they feel valued, retaining IPs longer, and how do we attract IPs to our organization and to our program. And so, spend a lot of time working on those sorts of things in this role now. I still do quite a bit of site visits. So I still am on site quite a bit, even though it's 15 hospitals. I try to get to all of them as much as I can. I'm still very connected to the local IPs there. So I have at least a monthly one-on-one with every single IP leader in our division, if not bi-weekly. And that's not for me to micromanage. That's for me to understand what their needs are and help them in any way that I can. So Again, it's kind of a shift back to the same type of thing I was doing at the Department of Health. That consulting, coaching, mentor, and support role is really what this looks like.
That's great. We haven't talked much about continued education at all. Obviously, at some point you went and got your CIC, you're a fellow of APIC. If I remember right, fellow of APIC also involves some publications that are requirements.
Mm-hmm.
So when did you do all that, and would you recommend it? And then also, I really want to give you a chance to talk about some of the management seminars you've done, because you've gotten involved with a lot of committees and
Mm-hmm.
things, not just attending a chapter meeting. I mean, you're heading up a lot of these things. So I really want to just let you talk about the philosophy behind that, what you got involved with, and then what obviously you focused on a lot of more management, which hearing your whole story makes a lot of sense as to why you're commenting on management. That's most of your career.
Mm-hmm.
But I guess share your most important message along those lines.
Yeah, so let me rewind back to the CIC. So I did get that when I was at the health department. And again, there was a financial incentive involved with getting that. So it was a pay increase, but it also demonstrates that you have a body of knowledge around IP. You know the foundation, and you're not proficient, but you're not at that novice level anymore. And actually, the mega surveys have shown that typically there's a $20,000 difference between a non-certified IP and a certified IP. I don't know that there's any research behind this, but I think it's easier to land positions if you're certified. It shows, again, that
For
you have
sure.
that body of knowledge, and you probably have at least 2 years of good, solid IP experience, enough to be able to pass the exam and get certified. So I do support certification. I think it's very important. I think it's necessary for IPs to really demonstrate what you know and have that credential behind your name. I got the fellowship while I was working at Tampa General Hospital. Fortunately, again, because it's a large program, a well-resourced program, there was opportunity even for IPs to do research or be involved with research while there. And so I did have several opportunities to be a part of research projects and also to publish papers with being one of the authors. And so that was something that I was able to contribute towards using to earn my fellowship in APIC as well. So, um, I don't see fellowship or anything asked for in any job postings or anything like that, but it is certainly something that I leverage when I have an interview. I'll say not all IPs have this. This is what it means if you're not aware. It demonstrates that I've contributed to the field in these ways. And it kind of sets you apart from those that don't have it yet, even if they're in the progress of doing that. So again, I strongly encourage the certification. That's a no-brainer for every IP. But if you have the ability to get the fellowship, all the things you have to do to get that will prepare you for your next steps as an IP. So it kind of makes sense to want to obtain that fellowship status as well. Um, in terms of the leadership piece of it and why it's important to me. So I know you didn't ask me this question yet, but I did see it in the questions, preparing for
Yeah.
this, is if there's one thing you wish you knew when you started versus what you knew now. I wish that I would have focused more on leadership earlier on in my career. I think as IPs, when we start, there's such a focus on the technical piece of our job. So the how do we do IP and the operational pieces of infection prevention. But there's not really a lot of conversation around the leadership aspects of it. And so when you look at the APIC competency model, leadership is a part of that competency model. So everything in that competency model, we should be working on at every stage of our career. But again, I think most times I see there's just such a focus on the technical piece of the job. And we all know if you can't communicate, collaborate, lead projects, influence change, be able to make a business case, be able to speak confidently in front of your C-suite and your leaders. If you're not able to do that, it doesn't matter what you know about the technical side of IP. you're not going to be able to be as successful in your program as you could be if you also had those leadership skills. So, anytime I'm at the table in terms of planning where we go next and working with APIC and what we need to teach our IPs and what they need, I always make sure that leadership piece is in there somewhere, and I know at some stages in your career, the technical piece obviously is a little more important, but we can't forget the leadership piece. We should start that as soon as possible. And so that way it's growing throughout that career as well. So when the time comes for you, you'll be able to step into that role and be as successful as possible. What I'm finding is IPs will be promoted because they're good at the technical piece, and then they'll get into the leadership position and not do as well because they didn't have the communication, collaboration, project management, big picture, type of experience to be able to support that move. So it's crucial that we learn about leadership. And so again, that's kind of my passion. So since it's something that I wish I knew sooner, that's all I talk about now. I think, and I don't mean this in any way, so I hope it's not offensive, but I think it's easier to learn the technical piece of the job than it is to learn the leadership side of the job. And so I would say as soon as you can start developing yourself as a leader, understanding, what your predispositions are, how your personality is, and how that plays into how you lead. Understanding your strengths and weaknesses and being able to compensate for your weaknesses, the sooner you can learn that about yourself and how to compensate, I think the more successful you'll be in your career.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.